everyone! Welcome back to my channel. What do you do when your current medication databases flags that there's an interaction with the drug that you're entering with a patient's existing medication therapy? Do you page the physician to recommend an alternative? Do you look into the severity of the interaction and what the evidence is backing it up? Or do you ignore it? Hopefully, we're not at the point of alert fatigue that we're choosing to ignore this interaction. As you all already know, not all medication interactions need to be avoided, and providing strategies to manage the medication interaction, especially when both must be given at the same time, is where I think the real value of a pharmacist is to a multidisciplinary team. In this video, I want to share my process on how I go about assessing a medication interaction that has worked for me in my experience as a clinical pharmacist. The first step is to determine whether there is an indication or a need for the two medications in question. Because if the medication is not needed, then there really is no point on going through this exercise. My second step is to understand the interaction. I want to know what the severity of the interaction is as flagged by the interaction database. I want to know what the mechanism of the interaction is, and most importantly, I want to know if there's any clinical or human data supporting this interaction and the severity of it. Usually your interaction database that you use, such as LexiComp, would have a summary of the interaction, so make sure you read that portion of it. These interaction databases will flag the interaction, but it does not necessarily mean that they are always clinically relevant. To determine whether this medication interaction will be clinically relevant to your patient, you must consider your patient's clinical factors, such as their medical history, their clinical status as of now, for example. To give you an example, if the medication interaction is additive QTC prolonging effect, then I will want to look into my patient's clinical history to see if my patient has any risk factors for developing torsades de pointes, which is the clinically significant event that we want to try to avoid with too long of a QT interval. So in this case, you might need to read more on what the risk factor is for developing torsades de pointes, such as being female, having a heart condition such as heart failure, and being elderly. If this is something that you encounter frequently or is relevant to your field, I can link you to a study below that goes over how to assess whether a QTC prolonging interaction flag would be clinically relevant or not to your patient. Now that you have a better understanding of the severity and the mechanism of the drug interaction, as well as its potential clinical relevance and the need for the medication therapy, then you'll want to know if this medication can be managed if the two medications must be given together. When looking up how to manage a patient's medication interaction, there are a few places you can look. First of all, you're probably already in an interaction database. Go to the summary because sometimes they will have a recommendation on how you can manage the interaction to avoid this. If your interaction database does not give you a recommendation, then I would suggest doing a quick literature search in Google or PubMed to see if there is any articles describing the management strategies for this interaction. If there's no information that you can find in the interaction database or in Google or PubMed, you might need to resort to your pharmacokinetic knowledge of the medication to see if there's a management strategy that you can logically come up with based on your understanding of the mechanism. Other factors to consider when managing a drug interaction would be the duration of the treatment. Is this interacting drug something that the patient must take for a long time or only for a short period? An example would be Paxlovid, where the ritonavir portion of the medication, which is a potent CYP3A4 inhibitor, interacts with many medications. But because of its short treatment course, a lot of the times it can be managed by holding the patient's other medication because of its short treatment duration. If the two medications are needed, are there any potential alternatives to this medication that could avoid this interaction and reduce the risk to the patient? And my last tip to you is that if you need to go down the route of recommending a treatment alternative, make sure you list out all of your treatment options and compare their efficacy, safety, your patient's allergies, and their ability to adhere to whatever formulation is available. Because the last thing that you want is that you recommend an alternative that also interacts with the patient's medication, causing you to need to retract on your plan, which can hurt your credibility as a clinician.